And then you rename it, madam, please. Dr. Padmini is Jaktiyal president.
Yeah, I have joined just now.
Yes,
Yes, sir.
then we can. Then two presidents are there.
Yes, ma'am.
Yes, we can start.
Yes, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Pinnacle News Series, Episode 21, PCOS and Endometriosis, in association with Jagityal, Matpalli, Hapur and Sagar OBGYN societies. So it's my privilege to introduce the moderator of today's webinar, Dr. Madhumita Arun Karthik, ma'am. Ma'am is the National Coordinator of Midlife Management Committee, FOXY, and Secretary of Salem Chapter of ISA. I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Sahiti. Good evening, respected faculty and delegates. It's a pleasure to invite you all for this Pinnacle News webinar series, which is organized by Professor Dr. Sampath Kumari, ma'am. Sahiti, can I have ma'am's slide, please? Yeah, ma'am is a professor and HOD of obstetric and gynecology at Sri Muthukumaran Medical College and Hospital, and she was a past vice president of FOXY, Senate member of T and Dr. MGR Medical University, national corresponding editor of Joggi, founder secretary of Tamil Nadu Federation of Obstetric and Gynecology, current president of OXY, and retired deputy director of Institute of Obstetrics and Gynecology at Chennai, president board of studies at MGR Medical University. She was a past chairperson of FOXY Adolescent Health Committee. She received the first ICOG Distinguished General Council Member Award, and also she's currently she's also the chairperson of Women's Wing IMA Chennai South, and she also received the IMA National President's Award and IMA Tamil Nadu State Branch Award. Next, before we go on to the welcome address, we'll have the prayer song and lamp lighting.
Yes, sir. So we'll go with the welcome address. Good evening to all. I welcome you all for this Pinnacle News Series. This Pinnacle News Series is the episode 21. We have societies from North, East, West and South. Today we have Jagatiyal, Kottulla, Matpalli, Hapur and Sagar societies. And I welcome Jagatiyal Society President Dr. Padmini and Secretary Srilata, and Kurutla Matpalli Society President Dr. Sweeti and Secretary Dr. Epsiba, Hapur Society President Dr. Anchana and Secretary Dr. Renu Bansal, Sagar Society President Dr. Jyoti and Secretary Dr. Nidhi Jain. For every series, we have two talks. Two sessions. One session being the talk, the other session being the panel. Now we have the first session, endometriosis in adolescent. We have the wonderful speaker, Dr. Ramani Devi from Trichy. She is the person. When we think about endometriosis, we will think only Ramani Devi madam. She is the queen of endometriosis. Then we have the adolescent PCOS, which is moderated by me with expert Dr. Jyoti, president of Sagar Society, with panelist Dr. Saranya, Dr. Sunanta, Dr. Chitra, Dr. Nidhi Jain, and Dr. Sundara Meenakshi. And we have the sweet moderators, Dr. Madhumita and Radhika Gauri. So I welcome you all for this webinar. Before we go with the scientific session, I invite the president, Dr. Jyoti Chauhan, to tell few words. Dr. Jyoti Chauhan, CV, please. She is the president of Sagar OBGYN Society. Recently, I have been to Sagar Society. Such a humble person, and we had a wonderful hospitality. And they were doing the program till night 10:30. They start the program by 7:30 and finish by 10:30 to 11. Dr. Jyoti, few words.
Ma'am, we have to thank you from the core of our heart because you took the trouble of coming all over from Chennai to Sagar, and the distance between Bhopal and Sagar is around 200 kilometers. You traveled the same day 400 kilometers on a road which was not very good. So, and you delivered your talk excellently, and your discussions were too good. Everybody said that such nice discussions we never had before. So we have to, first of all, thank you. And this topic that has been chosen today, PCOS, is actually a burning topic. And every day we come across many patients of this. So I think we need to discuss this, and endometriosis, which is, of course, rising these days. So both the topics that you have chosen are really very good. And I want to add to my CV that I'm the retired regional director of health services, Sagar division. Which includes 6 districts, which is Sagar, Damoh, Chhatarpur, Niwadi, and Tikamgarh. So
Madam, now I saw one thing from in a paper from Sagar district. What is that incident? I forgot. One small 3-year-old baby has been for the chess champion.
Yes, ma'am. There has been, it's a nice news for us that 3-year-old one is a chess champion, because we are having so many programs here. There is a new stadium that has been developed for all these activities. We have judo, and we have got judo and this karate champions also from Sagar. And this 3-year-old is the youngest so far. We also have badminton champions and others.
Yesterday I saw in the paper.
Yeah. So
anyway,
nice of you that you remember us.
Yes.
Thank you, ma'am.
Yes. I invite Dr. Padmini. She is the president of Jaktiyal OBGYN Society. Dr. Padmini, CV.
Yeah.
Dr. Padmini Kumar is senior consultant, Pallavi Maternity and Nursing Home. She is the president of Jaktiyal Society, Telangana, and president of Foxy 2006 to 7 at Karimnagar branch. At that time, vice president of IMA 2006 to 7 at Jaktiyal branch, and president of IMA 2007 to 2008 Jaktiyal branch. Welcome, Dr. Padmini. Few words.
Thank you, madam. Thank you. Thank you, madam.
Yes, yes, Dr.
Inviting
Padmini.
me. Yeah,
Yes.
thank you for inviting me, madam. And then these 2 wonderful topics you have taken, which is usually encountered in day-to-day practice. And then we are all happy to listen to the talk, and then we are happy to join with you. Thank you.
Thank you. Thank you, Dr. Padmini.
Yeah.
Dr. Sweeti, are you there? Dr. Sweeti and Dr. Anchana. I think they have not joined. When they join, we can introduce them. Now we will go with the scientific session. The first speaker being Dr. Ramani Devi Madam. Ramani Devi Madam, CV, please. She will be delivering the lecture on endometriosis in adolescent. Madam was the president ENFOG 2024 and the national vice president of Foxy 2020 and international advisory board member of Fertility Society of Bangladesh, ICOG governing council member 18 to 20 and Johi member. Currently she is and a patron of Indian Fertility Society and patron of our own TNFOG, EC member of Endometriosis Society of India. And Madam has got many gold medals and Foxy Awards, IMA Awards, Abdul Kalam Awards, Women Achiever Award, and delivered many orations, Navamani Bose oration, Ramasamy Nallusamy oration, and Dindukal Society oration, GCL Javari Symposium for the year 2019, and the Best Women's Award and ICOG Special Appreciation Award, UNICEF Certified Master Trainer for WOW, Satyapal Award in 2022. So she has many awards in spite of that. Madam is a best friend of mine, and she has got her PhD in endometriosis, the same topic, and she is the editor of many books. Wherever the book is on endometriosis, the editor or co-editor will be Dr. Ramani Devi. Dr. Ramani, madam, you can share your opinion.
Thank you, Sampath, for your kind words, and thank you for making me a part of this today's webinar. Okay, so
yes, madam.
I will. Okay, my screen is visible, no? Okay. Today the topic given to me is adolescent endometriosis, and I bring you greetings from Tiruchirappalli. Okay, Tiruchirappalli. I don't know for others. It is in the middle of the Tamil Nadu. For people who are away from Tamil Nadu, I am just informing, and you can see the beautiful river Kaveri and the UNESCO accredited Srirangam temple. And this is a painting that is seen in one of the Italy. It was an 18th century painting where you can see two young girls having in the hip, you can see the thorns, hip chain that is made up of thorns with apples and acorns that denotes, and a flushing in her face that denotes endometriosis, because it's the sort of gripping pain the adolescent girls have, or even any woman with endometriosis they have. Apples are symbol of fertility, and fertility is very much delayed in endometriosis. So when you consider this adolescent endometriosis, really does it exist? Is it different from the adult endometriosis? Then what are the risk factors? How does it present, and how it should be diagnosed? Why and how best it should be treatment, and how to prevent the recurrence, and how to preserve the fertility, how long you need to follow up the patient. So these are the questions which will flash into the mind. Okay. So by definition, endometriosis means normal endometrial tissue that is abnormally implanted in locations other than the uterine cavity. And when you consider the adolescent girls, stroma is much more than the glandular tissue. These implants will invade into their vicinity, causing inflammatory reaction. So the American Society of Reproductive Medicine says that endometriosis should be viewed as a chronic inflammatory disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding the repeated surgeries. But I have added two more important points. That is, apart from chronic inflammatory disease, it is an estrogen-dependent and progesterone-resistant disease. So basically, these two things are important because the medical management depends upon that. Again, the treatment goals are the child should be free of pain, fertility should not be hampered, there should be no recurrence, quality of life should be improved. So the prevalence of endometriosis it's a highly prevalent condition where 25 to 40% of the infertile women are having endometriosis, and 75% of the women with chronic pelvic pain, they have endometriosis. And when you consider the girls or women with dysmenorrhea, any patient with a dysmenorrhea always have a suspicion of endometriosis, especially progressive dysmenorrhea. Recent estimates according to WHO says that 246 million women, they suffer from endometriosis globally, and 50 million women belong to India alone, and 5 to 10% of the women suffering from endometriosis are in the adolescent age group. So in adolescence, the disease is often unrecognized, ignored, and mislabeled, and frequently that will result in chronic pelvic pain, adhesive disease, and infertility. An atypical presentation is more common. Early diagnosis and treatment may decrease the disease progression and prevent infertility. So the prevalence among teenagers are, overall prevalence, I said it is 5 to 10% of the teenagers, and 25 to 50% of the girls suffering from dysmenorrhea and atypical abdominal pain of chronic nature have endometriosis. And the onset of symptoms is usually, it starts occurring much earlier, less than 15 years, and the patient would have seen around 4 to 7 doctors prior to diagnosis, and the diagnostic delay may be even up to 7 or 9 years. It is seen that 50 to 75% of 70% of the teenagers undergoing laparoscopy for evaluation of chronic pelvic pain and dysmenorrhea, they have endometriosis. And prevalence is found to be much higher if the laparoscopy is done by senior endoscopy. Though earlier, the diagnostic test for endometriosis was the gold standard was laparoscopy, but now we know the algorithm has moved more towards the non-invasive diagnosis. That is, we can decide based upon the symptoms alone, we can start the treatment. So this is going to reduce the time for diagnostic delay, and this treatment may be started earlier. So what about why it is so important? Because there is not much of economic loss, and the common symptoms, I am very fond of telling it as 7 Ds, that is dysmenorrhea, dyspareunia, dysuria, dystacia, diffuse abdominal pain, difficulty in conception, and which everything will lead to depression and fatigability. And the diagnostic delay, I have already explained, it may be 7 years to 9 years, and there is loss of productivity. And there is also the women, they lose their work productivity is lost, as well as they have to spend money for treatment. So that is why it is going to be very important. You can see generally the phenotypic lesions are early superficial endometriosis, ovarian endometrioma, deep infiltrative, and adenomyosis. So earlier we thought that adenomyosis was a disease of third or the fourth decade, but now we know that even the young girls can have adenomyotic lesions, and again 30% of the patients, they have deep infiltrative lesion. So the risk factors are early onset of menarche less than 12 years, frequent and prolonged cycles, girls with a low BMI, and family history of endometriosis 6.9 times higher that they are likely to have in the siblings, parents, mother, and the aunts. So then the severe dysmenorrhea, the patient would have used oral contraceptive pill for analgesic effect and not as a contraceptive. So any girl using continuous oral contraceptive pill for severe dysmenorrhea, is the chances for endometriosis is going to be very high. And again, pain interfering with daily activities. The girl is not able to go to the school during menstruation. She takes leave. School absenteeism is most important thing. And again, dystacia and dyspareunia in deep dyspareunia in sexually active girls, it is found to be one risk factor. And neonatal uterine bleeding. Here I would like to add few points about the neonatal uterine bleeding. See, normally in the postnatal period, day 2 or day 3, we see that there is some amount of vaginal bleeding or discharge for 5 to 10% of the girl babies. So we take it for granted it is only the maternal withdrawal bleeding that is reflecting upon the fetal circulation. But on prolonged studies, they have found out, according to Eva Brosens, he says that girl babies who are having neonatal uterine bleeding are at high risk of developing dysmenorrhea. They are developing endometriosis at a later stage. Again, school absenteeism is a very important factor. And according to the ESHRE guideline, in adolescence, clinician to take care of should take a detailed history and identify the risk factors. For example, a positive family history, obstructive genital malformation, early menarche, and short cycles. Again, when they present with school absenteeism or when they take oral contraceptives for the treatment of dysmenorrhea, these are all pointers towards diagnosis of endometriosis in young age. So what will happen if the diagnosis delay is there? It will affect the quality of work, it will affect the future fertility, and the period of delay may be up to 7 years. So now then, how we are going to evaluate the adolescent girl whether she is going to have endometriosis or not? Best thing is history. Then go for the clinical examination. Clinical examination, per vaginal examination, we may not be able to do for all adolescent girls unless they are sexually active, or we can go for a per rectal examination and abdominal examination. And Q-tip test is one thing where it can find out the transverse vaginal septum or some sort of Mullerian anomalies, which will help to pick up that Mullerian anomalies are often associated with endometriosis. Again, imaging. Non-invasive modality is the best one for diagnosing endometriosis, and in imaging, ultrasound can be used and MRI. See, ultrasound in patients with adolescent girls with endometriosis, especially mild and minimal mild endometriosis, there may not be any ultrasound evidence in a simple transabdominal ultrasound. And in stage 3 and stage 4, that is endometrioma, you can visualize it in ultrasound. But now the Monash group of people from Australia, they have come out with what is called as IDEA group to identify the deep infiltrating lesions based upon imaging. That is, indirect evidences are there, like a retroverted uterus, a bulky uterus, where the ovaries are closely adherent. Although, and whenever there is a failure of this mobility of the organs are there by imaging, then they are all indirect evidences the patient is going to have endometriosis. Then biomarkers. Biomarkers, generally we say that CA125 is a biomarker, but we have to understand it is non-specific and it may be positive in so many conditions, and but only for follow-up of endometriotic patients, CA125 can be used. But I'm sure though the ESHRE guideline says that biomarkers can be used only under research purpose, day is not far off when we will come out with biomarkers, suitable biomarkers like microRNAs, which may help in diagnosing endometriosis much earlier. So the history is, you should ask about the pain, what's nature of the pain, whether it is associated with the menstruation or in between, whether she has got bladder bowel symptom. And sometimes we have to ask whether it is interfering with the daily activity, and history of contraceptive use and sexuality that has to be elicited. And recurrent pelvic inflammatory disease. Sometimes these patients will be complaining of chronic pelvic pain, and they would have even consulted a psychiatrist, because there won't be any clinical evidence to say, compare between the pain of the patient and the disease. So this is what the 70s I'm very fond of. Then you don't think that these symptoms are isolated. There is always a combination of the symptoms. For example, the same patient can have dysmenorrhea associated with diffuse abdominal pain, or it can be an acyclical pain. Acyclical pain has to be differentiated from cyclical pain. To begin with, all endometriotic patients will have cyclical pain, but as the disease progresses, it becomes widespread and the pain will be there throughout the cycle. So this is what is called as Teens Pain Diary that is being followed up in Boston, where there is a hospital exclusively for adolescent endometriosis, where Professor Eva Brosens is working, where they will identify based upon the symptom, the pain calendar is maintained, and based upon this, they can come to a conclusion, like that documents the severity of pain in relation to bowel, bladder, missing school, social activities. They all need intervention. So physical examination, you have to rule out Mullerian anomalies, abdominal and rectal examination, Q-tip test, and rectal examination may show uterosacral nodularity, endometrioma, and type. So there is another way of diagnosing it. That is, when the patient presents with dysmenorrhea and chronic pelvic pain, we can give them a trial of drugs. Generally, for dysmenorrhea, we start the patient with NSAID, which will be very comfortable and mainly for primary dysmenorrhea. But whereas in dysmenorrhea secondary to endometriosis, initial phases, the patient may respond, but later they may not. Then use of continuous OC pill or cyclical, or the patient can be given a short trial of GnRH analogs or antagonists or dyneges. If the patient gets settled, the pain settles, both cyclical and acyclical pain, then we may come to a conclusion that the patient is suffering from endometriosis. Ultrasound, you can see a beautiful endometrioma. This was my real case taken in a 16-year-old girl. It can be unilateral or bilateral, kissing ovaries, and it can be multiloculated, and the mobility may be restricted, and there is site-specific tenderness, and you can see the mural nodule here, and there will be low-level echoes, and sometimes layering can be there. That means in the layering, the deepest portion will have the clot, and superficial portion will have the thin hemorrhagic areas. So then there may be nodular wall thickening. So then again, 4D, 3D can help, and generally we have to differentiate this from a dermoid, which is very common in this adolescent girl, or neoplasm. In neoplasm, you see the normal endometrioma where there is surrounding vascularity, but in a neoplasm, you can see inside the tumor also, because these neoplasms can happen. Some of the germ cell tumors can happen, 1 to 2% of the girls. Again, in a transabdominal or transrectal, see, you can see the deep infiltrating lesion where the rectum is involved. Here again, both the ovaries are being kissing ovaries in the middle, and you can see the nodularity, the rectovaginal septum is involved in this. So then CT scan doesn't have any role except in scar endometriosis. And in patients for whom you cannot diagnose endometriosis through ultrasound, maybe MRI will help. Especially, it will help to differentiate endometrioma from dermoids and other germs and tumors. And again, you can see the associated adenomyoma in the posterior wall. You can see the involvement of the rectovaginal septum and the upper portion of the fornix. All those things can be clearly made out. And especially when the patient has got a Mullerian anomaly, MRI gives the best result. What is the type of Mullerian anomaly the patient has? So coming to the ESHRE guideline, should take a detailed history regarding the chronic and acyclical pelvic pain combined with nausea, dysmenorrhea, dysphagia, dysuria, dyspareunia, or it could be a cyclical pain. So before GDG recommends that before performing vaginal examination or rectal examination, with the patient should be and the caregiver should be explained what we are going to do, and they should give acceptance. Transvaginal scan is recommended in adolescents for whom it is appropriate, like sexually active adolescent girls, for diagnosing ovarian endometriosis. And if it is not appropriate, maybe transabdominal or transperineal, transrectal scan or even MRI can be done. So now optimize the diagnosis. This is Professor Chapron, who's a doyen in this field, and he mainly deals only with the endometriotic patients. And now he says there is no need to have any histopathological evidence. A simple history-based evidence is enough to start the patient on medical management. So then there is a place for microRNA. This is my field of interest, where now we have come out with certain microRNA, miRNAs, which are dysregulated in patients with endometriosis. And here it does not depend upon the stage of the disease, previous treatment, and the phase of the menstrual cycle. So the ESHRE guideline says that we should not use biomarkers in endometrial tissue, blood, menstrual fluid to diagnose endometriosis, but definitely it will come in days to go. So these are our publications regarding the non-invasive diagnosis of endometriosis in patients who are having early endometriosis. These are some of our publications. Now, the available treatment is we need to treat the patient medically or surgically. For the pain is very important that we have to get rid and again promote the fertility. So the concept of the medical management is we need to suppress the estrogen, because I have already mentioned it is an estrogen, hyperestrogenic disease. You have to reduce the retrograde spread, because it is, if you think about the etiopathogenesis, the retrograde spill of the blood gets implanted in the peritoneal cavity due to certain MMPs, etc. And the VEGF is also high, so thereby promotes the vascularity and grows into endometriotic tissue. And there is progesterone resistant, and we have to overcome that. And it is a pro-inflammatory condition, hence anti-inflammatory drugs can be used. And there is increased aromatase expression, both the central as well as each tissue has got increased aromatase expression. So this has to be handled. And again, anti-angiogenic, because of increased VEGF and neural element are there in endometriosis, that has to be suppressed. And it is an immune modulatory disease. Immune aberration is there, so we can manage it by modulating it. So the common drugs nowadays, what we are using is NSAID for pain relief, combined oral contraceptive pills that should be given continuously, GnRH agonist, and the progesterone. But now we have the latest second line of drugs, namely oral GnRH antagonists, that is elagolix, relagolix, and lintagolix, progestins and progestin antagonists, that is selective estrogen receptor modulators and progesterone receptor modulators. And again, we have the aromatase inhibitors, anti-angiogenic drugs like gabapentin, quinabolide, etc. Statins, that can rosuvastatin and atorvastatin are found to have an anti-inflammatory as well as it suppresses the vascularity. Hence, they are under trial. And estrogen receptor beta-glucan. This is one drug, because you know that all these drugs are all contra-reproductive. The patient cannot conceive. But whereas this is the estrogen receptor beta-glucan is the one drug which will suppress the estrogen beta receptors. So thereby it reduces the progesterone when the estrogen receptor beta, which is high hyperestrogenic status, is being suppressed, and the progesterone resistance is being controlled. So this can promote fertility. But there are certain limitations of medical management, namely, it gives symptom relief only when the patient is on treatment, you have to think about the side effects like bone mineral loss, mood changes, irregular bleeding, and recurrence is very common after discontinuation. So now our goal is we should give the pain relief, arrest the progression of the disease, and preserve the fertility. How we can achieve? So these NSAIDs are the commonest drug. This can be administered during or before the onset of period. Mefenamic acid, ibuprofen, naproxen, COX-2 inhibitors, and the side effects we know, of course, gastritis. But this is one drug which can be used in a girl who's planning for pregnancy because it will not inhibit the ovulation. Then comes the continuous oral contraceptive pills. It should be given continuously for 3 months. It gives good relief of dysmenorrhea and it is quite safe in adolescent. And when we are using this oral contraceptive pill, it should be a low dose estrogen content. That is very important because we know the disease is an estrogen dependent one. And if you are going to give a pill which has got a high estrogen dependency, high estrogen content, it is not going to work. And again, these are all the references by Professor Chapron, Versilani, who are all not for use of oral contraceptive pill as a first line management because it will suppress only the symptoms and the underlying deep infiltrative lesion will progress. So the guidelines, what the guideline says, we have to give hormonal contraceptive comes under level B. Now the level A evidence goes to progestins. Progestins and GnRH antagonists or agonists. So what is the role of progestin? According to the ESHRE guideline and the World Endometriosis Society, progestins are found to be the first line management for endometriosis. And there are now we have the newer progestin, that is, I won't say it is newer, dynages that has been in use for more than 10 years and it is found to be a very safe drug. So again, the ESHRE says we can use any progestin, MPA, medroxyprogesterone acetate can be given orally or in a depot form. Dynages, cyproterone acetate we don't use. Norethisturion, our simple primoluten, that is a very effective drug for control of pain, especially in DAE patients. And we can have danazol, can be used in certain situations. We don't use antiprogesterone gestatinone because it is not available in our country. Okay, so the progestins, they act. How do they act? 75% of the patients receiving progestins, they experience a reduction in the pain and very effective in treating endometriosis-associated pelvic pain. It can suppress MMP, it can suppress the growth factors, it suppresses the inflammation, peripheral estrogen level is also suppressed, and as because of all these actions, it will suppress the endometriotic implant. So among the progestins, we can use norethisturion can be given 15 milligram per day. Medroxyprogesterone should be given starting dose of 30 milligram per day, or subcutaneously we have the 104 milligram injectable depot, or the common routinely used 150 milligram depot injections can be given once in 3 months, and it can have a side effect of nausea, weight gain, fluid retention, breakthrough bleeding, and we cannot use for more than 3 years because of the reduction in the BMD, but still it is found to be a very cheap, good drug. Dynages is one effective drug. It should be given at the dose of 2 milligram, anti-proliferative, anti-angiogenic, anti-inflammatory effect, and it is pain relief is comparable to GnRH agonist, and it has got a minimal side effects and tolerability is good. So this is how it works in the ectopic endometrium. All anti-angiogenic, immunomodulatory, anti-inflammatory, and pro-apoptotic thing is there. So thereby it reduces the pain, reduces prostaglandin, reduces tumor necrosis alpha, promotes the apoptosis. All these things are helpful. Okay. Then there is one study what they have done. That is the Visada study, which was done in 21 centers across 6 European countries to say that Pediatric Committee of European Board has approved this drug for adolescent endometriosis. Danazol was the first drug to be mentioned in treatment of endometriosis, but we know it is out of the scene because of the side effects. But still, there are oral tablets. Instead of oral tablets, vaginally it can be used with a minimal dose of 50 to 100 milligram, and danazol-loaded IUCDs are also available in certain countries. Then comes the GnRH agonist, what we were using very much, and we have various girls beyond 16 years, they can be put on this, but you cannot use GnRH agonist for a longer time, only for a shorter period, 3 months to 6 months. And it should give a add-back therapy because it can cause BMD reduction, hot flashes, reduced libido, osteoporosis, etc. Now we have this wonderful molecule that is the elagolix, which will cause direct downregulation of the gonadotropins in contrast to the GnRH agonist, where there is an initial flare-up effect with the side effects. This is not so much with elagolix, and again, elagolix is dose dependent. For patients who are having a mild pain, you can give a reduced dose of 150 milligram, or in patients with deep infiltrative lesions, you can give 200 milligram BID dose. So with the minimal side effect. Then comes the LNGIUS in adolescent girls with severe dysmenorrhea and menorrhagia or associated adenomyosis. Maybe the patient can be started initially on Dynagest or GnRH analog. Then again, it can be inserted to when the patient, as it has got contraceptive benefits, reduces the pain due to endometriosis associated pelvic pain, as well as adenomyosis is kept under control. So initially, you can give the patient GnRH analogs for a few months, followed by LNG-IUS insertion. And aromatase inhibitors, they are the second line of drugs. Either you can use letrozole or anastrozole for a period of 6 months very safely, because this has an action upon both this, like it inhibits aromatase is overexpressed in endometriosis, so it cuts that aromatase overexpression. So the production of estrogen is reduced. Moreover, the aromatase overexpression is seen in each endometriotic nodule that can also be suppressed with it. So with all these drugs, we went to shift the patient to surgical management. When the patient has got chronic pelvic pain, dysmenorrhea, not responding to drugs, or when the patient has got endometrioma or once again, not responding to medical management and affecting the quality of life, sometimes the patient may not tolerate the drug. And especially in patients with the Mullerian endometriosis, Mullerian anomalies and endometriosis, medical management fails, and it is surgery where the correction of Mullerian anomaly will promote the symptoms. And again, there are emergency situations like rupture of endometrium or torsion. Torsion is usually rare because of adhesion. So preoperatively, we have to evaluate the AMH level, detailed imaging. Senior surgeon should do microlaparoscopic. There is no place for laparotomy. We need to go for a laparoscopy, and extensive counseling regarding the reduction in the AMH and the extensive surgery the patient may need if there is associated DIE. So the principles to be are followed are aim at eradicating the lesion. Earlier, we were only cauterizing these lesions, but we know now that excision of the entire peritoneum will help in disease clearance. So this is the laparoscopy of a 18-year-old girl with the endometrioma, where you have to really remove only the cyst wall should be carefully removed without damaging the ovarian cortex. So it should be done preferably in the follicular phase, and then addisolysis and cystectomy should be done. The lesion should be cauterized, and try to use only minimal cautery, only whenever there is bleeding. Adhesion preventing agents can be used. Again, if you don't find any finding in the pelvis, then you put in hydroflotation and you can find out, or sometimes they say even a biopsy can identify that. So this is hydrolaparoscopy, or what is called as a transvaginally through the posterior fornix, the laparoscope can be inserted and you can identify the disadvantages. You cannot visualize the anterior compartment. So these are some of the lesions of early lesions. And here you see the Allen-Masters windows or the peritoneal folds. And usually there is some amount of that is hemorrhagic fluid. See, you can see the peritoneal fields. These are folds. These are all the typical findings of endometriosis. And this is called Allen-Masters window. So the guideline is in adolescents with suspected endometriosis where imaging is negative, medical treatment, if it is not successful, diagnostic laparoscopy should be considered. And if laparoscopy is performed, clinician should consider taking biopsies to confirm the diagnosis histologically, although negative histology does not rule out the disease. So I will just go through some of the cases. 19-year-old girl with complaints of severe abdominal pain, progressive for 2 weeks, history of dysmenorrhea plus low-grade fever for the past 1 week. There is no family history suggestive of endometriosis, and the child was only one child. The same, that was the picture what I had shown earlier. She had a BMI of 17 with a see vague fullness in the lower abdomen, and rectal examination showed a fullness in the right fornix. So when we took the serum biomarkers, these markers, the CA-125 was found to be beyond 2100, and all the other germ cell tumor markers were negative. MRI confirmed the finding, and in view of elevated CA-125, she was posted and the AMH was found to be 3.2. So this was one of my old videos where you can see the rupture of the endometrioma showing all this brownish tissue. So proper cystectomy was given, thorough lavage was given, and the other ovary was found to be normal. So this, after surgery, after 3 months, this was the picture where both ovaries were found to be normal. She was put on Dynages continuously, and intermittently she was switched over to oral contraceptive pill also. She got married. This surgery, she had it at 19 to 20 years. She got married at 25 years, and she was advised to start on dydrogesterone 5 to 25 days, because dydrogesterone is again a progesterone which will not inhibit ovulation. So this particular patient conceived, and this was a post-operative during LSCS. We could see beautifully the right ovary which had the thing. So this was another patient who had an unmarried girl, college-going student, where she came with severe abdominal progressive dysmenorrhea and had large endocysts, and she was started on Dynages, but it did not regress. So see, the uterus was also adenomyotic. Both sides ovaries were beyond 6 to 7 centimeters, and abdominal survey was done. This was the laparoscopic view where you can see the huge adenomyosis and huge endometrioma, and you can see this vesicles which are evidence of early endometriotic spots. You can see this blebs. So this patient underwent bilateral cystectomy, and again she was, we should be very careful in removing only the cyst wall has to be removed, and this patient was put on post-operative suppressive therapy with, again, she was continued. Initially, I started after the surgery, I had put her on GnRH antagonist, and now she is totally free of pain, and now once again she switched back to Dynages, and this was the picture I've taken 3 months later, where you can see both ovaries in normal position with good follicles. So this was another girl who was referred to me at the age of 13 to 14 years with a progressive dysmenorrhea. See, on ultrasound, we could see one horn of the uterus, which was showing obstruction, right side, and the absence of kidney on that side. This is a case of Erlen-Werner syndrome. This is a symptomatic, this is a pictorial diagram where the obstruction can be at anywhere in the vagina or in the cervix, and this will be ipsilateral absence of this kidney. So this patient underwent surgery. Now you can see there is hematometra on one side, and the other uterus was other side was normal, and this was the laparoscopic view where you can see this endometriotic endometriomas and also this addition. So this patient, because it was at the level of obstruction was at cervix, hemihysterectomy was done. She came for proper follow-up, and she was put on post-operative suppressive therapy, and she conceived and delivered. So ultimately, the lifestyle modification and dietary things are very, very important. Exercise, avoid trans meat, promote omega-3 and fruits and vegetables, and say no to this. No dairy products, refined sugar, meat, and soy byproducts. Now they say it can be safely given. Isoflavones can be given. Avoid caffeine, saturated fats, and oil. So with all this thing, whatever treatment, can you prevent the adolescent endometriosis? If you treat it, can you prevent adult endometriosis? I think it is not possible, because we are not correcting the etiopathogenesis that persists. Exception is Mullerian anomaly, and we have to have a constant follow-up. So the future directions will be AI-based. Role for biomarkers are there. Non-invasive imaging should be promoted, and personalized treatment should be there. So Endo like to say, it roots at birth, starts at 20, progresses at 30, problematic at 40, supposed to end at 50, malignancy risk at 60, needs follow-up forever. So education is the most powerful weapon which you can use to change the world. And with this, I come to the conclusion and I thank Dr. Sampath Kumari for having given me this opportunity of giving my talk on adolescent endometriosis, and I wish her all the best for her future endeavors. And I request all of you to support her from all over India to support her. I think she will be a wonderful, wonderful president in future. Thank you.
Thank you
so much.
madam. Thank you. See, Ramani madam needs no slides. Without slides, she can talk this endometriosis. For want of us, she has projected the slides. So the endometriosis is so close to her heart. Thank you, madam, for the wonderful talk as usual. Now we will go with the second session. Madhumita, அவங்க ஸ்வீட்டி ஏதாவது
Yes.
ஜாயின் பண்ணிருக்காங்களா?
Yes, ma'am. Yes, ma'am. Add பண்ணியாச்சு.
இல்ல ஸ்வீட்டி ஜாயின் பண்ணிருக்காங்களா? ஹப்பூர் சரி ஜாயின் பண்ணல. Yes, we will start with
Shweta Dubey join பண்ணிருக்காங்க. Smita Dubey ma'am join பண்ணிருக்காங்க.
Dr. Smita Dubey is from
Sagar.
Sagar.
From Sagar.
Yes, welcome. Smita Dubey is no other secretary has joined, I think. Smita Dubey, you can tell some few words about the webinar. Are you there?
Yes, ma'am, I'm there.
Yes, welcome.
Okay.
How do you like this endometriosis? Ramani madam's talk.
Yes, very nice, very explanatory.
Wonderful talk.
Wonderful talk, yes.
Yes, we will go with the panel. Yes,
ma'am. Thank you so much, ma'am. So moving on to the second session, we have very interesting panel on adolescent PCOS, and we have our moderator who's none other than Dr. Sampath Kumari ma'am, and we have ma'am and we have expert Dr. Jyoti Chauhan. Ma'am is she has won numerous awards, and she was also, and she's been been awarded the Inspirational Teacher Award in 2024, and also she's awarded the Chikitsak Alankaran Award in 2018.
Okay, let's move on to the next.
Yes, ma'am. Yes, and we all know her as the president of the Sagar Obstetric and Gynecological Society, and she's also won the DD Tank Award for the best RCH activities. And we have our eminent panelists.
President's Rotating Trophy Award.
Trophy
That
Award.
is very important.
Yes, ma'am. We have Dr. Sarnya Devi, who's a member of Salem Obstetric and Gynecological Society. Next slide, please. Dr. Sunanda, again a consultant at Salem. We have Dr.
Fellowship
K.S.
of Dr. Ramani Devi.
Yes, student of Ramani ma'am student. Dr. K.S. Chitra, consultant obstetrician gynecologist. Dr. Sundara Meenakshi, who's the joint secretary of Obstetric and Gynecological Society of Salem, and also she was assistant professor at Salem Government General Hospital. Next, we have now Dr. Nidhi Jain, who is the secretary of Sagar Obstetric and Gynecological Society.
Whether Nidhi Jain has joined, I don't think she has joined.
He said
Yes.
she's joined.
Anyway, we will proceed. Madhumita, yaar ipa
So
panelist
Dr. Radhika Gauri. is the next
Radhika
panelist.
Gauri,
Yes.
she is there.
Yes, ma'am. She's joined as a panelist. Ma'am.
Yes. So Chitra Sundara Meenakshi,
Dr. Chitra has joined. Chitra ma'am, can you rename yourself, ma'am? Yes, ma'am.
Sunanta, and
Good evening, ma'am. Sampath
yes.
ma'am, good evening.
Welcome. Wow. Yes, thank you, Madhumita.
Yes, ma'am.
We will start the panel. I welcome our expert, Dr. Jyoti, and the panelists, Dr. Chitra, Dr. Sundara Meenakshi, Dr. Sunanta, Dr. Radhika Gauri, and Dr. Nidhi Jain. இன்னொருத்தர் யாரு?
Ma'am, Dr. Sunanda, Dr. Sundara Meenakshi is there, ma'am. Dr. Chitra, Dr. Radhika Gauri, Dr. Saranya Devi.
Saranya. Yes, Saranya is there.
Yes,
Yes,
ma'am.
we will go
Five
with that panel. That is our practical only, whatever we are discussing. Yes, slide visible.
Yes, ma'am.
Yes, ma'am.
Yes, we will go with that. I welcome the expert and the panelist for this wonderful discussion on adolescent PCOS, which is the need of the hour. Every patient will come with the ultrasound report telling that it is an adolescent PCOS. See, I welcome Dr. Jyoti, Dr. Chitra, Dr. Sundara Meenakshi, Dr. Saranya Devi, Dr. Nidhi Jain, Dr. Sunanta, and Dr. Radhika Gauri. So the term adolescence, as all of us know, it is a transition from childhood to adulthood. The adolescents are neither the children nor the adult. So whatever we tell, they tell, we should take into account and we cannot neglect them also. We should streamline them because future country is only this adolescence. The adolescence as per WHO is early adolescence from 10 to 13 years, during which the spurt of growth development of secondary sex characters appear. Middle adolescence being, they need the identity. They want separate identity at the age of 14 to 16 years, and they are attracted by the opposite sex. That is why we call it as the sweet 16. And the late adolescence being 17 to 19, they have the well-formed opinion and ideas. Now this India's adolescents are 253 million. Why we want to talk about the adolescents is because the population is around 22% of the populations are adolescent. So India has the highest population of adolescents throughout the world. So the adolescence has to be focused on nutrition. As all of us know, that it has changed the breakfast and fast food items, the menstrual health regarding the menstrual hygiene. We have to talk even about the menstrual cups. Then the reproductive regarding the teenage pregnancy and sexual abuse, abortions, and the sexual health. We should know the adolescents should be in a position to tell no whenever they want to tell the no. For certain things, suppose if a boy follows and if the boy proposes, if she is not liking, she can tell no. And the social health, we have to always teach them how to respect the seniors. These are all the field which has to be taken. And finally, the mental health. The adolescents, they don't have the patience. Sometimes the immediate decisions. That is the reason the suicidal tendency has increased with the adolescents. Then finally, the vaccinations. The vaccination is very, very important. Now we all talk about the HPV vaccination. That is the 2030 goal. 90% of the adolescents has to be vaccinated and 70% of the women has to be screened and 90% of the women has to be treated from the screened, the appropriate treatment. Now we will come with our topic, the menstrual problem, that is the PCOS. PCOS is not a disease, but an ill-understood phenomenon defined in various forms over the years. In our clinic, we usually see the girls, they are not bothered. The mother, they will come and she will ask, my daughter is having PCOS, whether she can get married, whether she will deliver. These are all the routine questions as all of us are facing. This is as the PCOS is mainly the multifactorial heterogeneous syndrome and characterized by ovulated dysfunction and hyperandrogenism. If you don't identify, most of the time it is over-identified. If you don't identify, it can produce the complications in pregnancy as GDM and later the increased risk of the metabolic syndrome. So management in adolescent is very, very important to avoid the immediate and the long-term sequelae. So the menstrual cycle, as all of us know, the proliferative phase, then the secretory phase, where there is a FSH-LH ratio is disturbed. It goes to the multiple follicle rather than the single follicle released during the ovulation. This is the PCOS. Now we will come with the common pathophysiology. We will go with Dr. Sundara Meenakshi. Can you explain the pathophysiology of our PCOS? In adult.
Ma'am, ma'am, am I audible, ma'am?
Yes, you are audible.
Ma'am, PCOS is a multifactorial disease, ma'am. Syndrome, actually it is. It is because of insulin resistance and hyperinsulinemia. This hyperinsulinemia acts upon the ovaries. And synergetically, it increases the LH stimulation by the theca cells. And the theca cells produce androgens, androstenediones and testosterone. And this LH also, this hyperinsulinemia also affects on the liver and it reduces the secretion of sex hormone binding globulin. And hence there is free circulating androgens in the blood. So this is the reason these patients, they have androgenic features, ma'am. It is a metabolic disorder, ma'am.
Yes. Yes, Sundara Meenakshi has told very well. The main reason being the hyperinsulinemia and hyperandrogenism. which acts on the liver and the adrenal, which produces the reduced serum hormone binding globulin and elevated DHEAS. As such, there is free androgenous increase. And with the HPO axis, the stroma and produces the elevated androgens, which also produces the multifollicles. As she has explained to us very well. Thank you, Dr. Sundar Meenakshi. Can you
ma'am.
define PCOS, Dr. Sunanta? You are there, no? Dr. Sunanta.
Ma'am, am I audible, ma'am?
Yes, Sunanta, you are audible.
Yeah. PCOS is in a teenager. It is defined as irregular menstrual cycle. That is, she is menstruating less than 6 times in a year, with or without features of clinical or biochemical hyperandrogenism.
So as you told, see, it doesn't mean that for an adolescent girls to have every month the bleeding. Normally 8 cycles. As she told, it is more than enough. Dr. Sunanda, do you have any criteria for adolescent PCOS? You know very well that 90% are due to obesity. 10% is lean PCOS. Do you want to follow any criteria for this adolescent PCOS?
Yes, ma'am. The patients will have anovulation, or they will have clinical or biochemical hyperandrogenism with or without PCOS features, ma'am.
Do you want to consider this ultrasound features for adolescents?
In less than 8 years of menarche, we should not consider ultrasound features of PCOS, as there will be multicystic ovaries in adolescent age groups.
Otherwise, also for adolescent, if there is irregular menstruation and if you have future clinical or biochemical hyperandrogenism, insulin resistant symptoms present, you can take. Because as all of us, we know the follicles are studied by the transvaginal probe. We don't go with the transvaginal probe. As far as PCOS is concerned, the morphology of the ultrasound is not needed. But still, we are taking into account of many patients with the abdominal examination, they come with that features. Now we'll go with Dr. Radhika. What are all the symptoms you find with the PCOS adolescent? The mother is much worried, no?
Yes, ma'am. PCOD, the girls have from the head to foot, they can have hair loss, and then they can have acne, pimples, and they can also have, there can be obese or they can be lean also, but most common is the obese PCOD, and they can have irregular periods due to anovulation, and that is the main, and oligomenorrhea also. Oligomenorrhea are very scanty periods. And some women can have every 3 to 4 months heavy periods also. Some adolescents can present. And they also, due to all these things, they can also have psychological, like their confidence might be less also. And sleep issues they can have. But the common ones are these alopecia, hirsutism, main thing, hirsutism, obesity, and those are the main things, ma'am.
Yes, Radhika. So the 90% are obese, and the main complaint will be menstrual abnormality. As she told, it may be oligomenorrhea or with amenorrhea followed by the bleeding. And
Yes,
with the androgenic features, hirsutism, acne, alopecia, mainly the frontal lobe alopecia will be present. If there is an insulin resistant cases, acrocordons and acanthosis. Acanthosis is the blackish colorations over the neck, and acrocordons will be a skin tag over the neck. That is the acrocordons. If it is present, insulin resistant. Then you go with the infertility, polycystic ovary. For completion, we have most of the time ultrasound is not taken into account. So the scoring system, hirsutism, I think Dr. Saranya is there. Can you explain the hirsutism scoring system? Dr. Saranya, how will you tell that the patient is having the hirsutism? Dr. Saranya, are you there? Dr. Chitra?
Yes, ma'am. Audible.
Yes, Dr. Saranya. You explain about the hirsutism.
Ma'am, with modified Ferriman-Galway scoring system, hirsutism can be scored, ma'am, by presence of hair in the upper lip, chin, chest, upper back, lower back, and upper abdomen, upper arm, forearm, leg, and all. We have to score them, and when the score comes more than 8, it indicates hirsutism, ma'am.
Yes, Saranya. So if it is more than 8 only, sometimes the patient will be having a small growth over the upper lip and they will be much worried. So the main thing is you have to counsel. If all these places is present and the score is more than 8, we consider them as the hirsutism, and then we go with the biochemical features of the hirsutism. So the hyperandrogenism, mainly the frontoparietal baldness, acne can be present. Most of the time, the acne will be present. Once the bleeding has stopped, it will go off. So in that cases, we don't consider them. And the lesions in the boils can be present in the blackheads. Now our expert, Dr. Jyoti, is there. Dr. Jyoti, do you want to tell anything in this point?
Yes, ma'am. There is a small point that we missed initially when we were talking about the etiogenesis. The
Yes.
genetic factor also has to be there, and we
Yes.
should take a detailed history, and you'll find that the female candidates in the family are also having PCOS.
Yes, as madam is telling them, it is a multifactorial. The genetic factors is more important.
Yeah.
Yes,
And,
madam.
and one more thing, ma'am. The family history, mother, most of the time, mother is diabetic, ma'am. At 40 years, mother,
Definitely.
mother, yes, ma'am.
They also have that. Now we come with the insulin resistance. Suppose the patient is having the acanthosis nigricans. We consider them as the insulin resistance cases. And how will you go with this insulin resistance? Dr. Jyoti madam, how are you doing this insulin resistance in your place?
Ma'am, we are following the same criteria that you have mentioned. We let the patient have 75 grams of glucose, and after 2 hours, we take the levels of sugar. If they are the fasting levels, the postprandial levels, if they are 140 to 199, then we consider it as impaired, and diabetic if it is positively more than 200. This is the same criteria that we are following.
Yes.
Fasting
always
we
for
do the other day.
Yes, madam. Thank you. So always for the insulin resistance, you don't go with the fasting insulin. Only this 2-hour GTT is important. Fasting insulin has no value. Okay. Now, do you know about the adolescent metabolic syndrome? Dr. Chitra, are you there?
Yes, ma'am.
You consider it as an adolescent metabolic syndrome. Yes, Chitra.
Ma'am, actually, three or four criteria we have to take it, ma'am. Blood glucose more than 100 milligram for the receiver, or high density lipoprotein C less than 40 milligram. If triglycerides goes more than 110 milligram, or the waist circumference is more than 90th percentile for the age and sex, and if blood pressure is more than 90th percentile for the age and sex. Oh, any 3 of the 5 criteria we have to take, ma'am.
Yes, definitely. As she was telling, the BP, triglycerides, glucose, HDL, and waist circumference. If all is increased or decreased, we have to, this triglycerides, HDL alone decreased, but other things, everything is increased. We, as all of us know, HDL is a good cholesterol. So if any 3 is present, this patient is prone for metabolic syndrome in future. This is the adolescent metabolic syndrome. So Chitra, how are you going to differentiate diagnosis of this PCOS?
So actually, we have to investigate for thyroid disorders, and if suppose she's going for infertility, LH, FSH, everything, ma'am. So differential diagnosis like primary thyroid disorder, hyperprolactinemia. We have to go for check for prolactin level also. Congenital adrenal hyperplasia, androgen screening tumors also we have to rule out, and severe insulin resistance syndrome, Cushing syndrome, and idiopathic hirsutism, ma'am.
So this is the disease of exclusion. As she has explained very well, this is a disease of exclusion. Jyoti madam, do you want to tell anything in this point?
Sometimes galacturia is also there along with hyperprolactinemia. That is what we observe.
So the history has to be elicited from this. I think the adolescent girls may not be knowing that. We have to explain to them. So what are all the investigations you do, Dr. Sundara Meenakshi? A girl comes with a history telling that somebody has told her adolescent PCOS. What are all the investigations you want to tell, do?
Ma'am, from the history itself, we can know that because if she's like post-menarche, less than 8 years, so ultrasound will not give us a much significant value because adolescent. So first thing, I will not go for an ultrasound. Next thing which I would like to do for this patient is definitely, because it's a disease of exclusion, I would like to do a thyroid profile, prolactin, and 17-hydroxyprogesterone to load non-classical congenital adrenal hyperplasia, and otherwise I will definitely do for this patient as madam has already told, 75 grams glucose test. I will do it, and then fasting insulin doesn't have a role, so I will not do. FSH/LH doesn't have a role. I don't want to do. AMH also doesn't have a role, so I will not do for that. This specific adolescent PCOS, ma'am.
So you will do.
I will definitely go ahead and do. I will definitely do a lipid profile for this patient.
Yes. So thyroid, prolactin, 17-hydroxyprogesterone, lipid profile, and GTT. FSH, LH, AMH is not needed. That is the test which is needed for the test. We are not going with, as Sundara Meenakshi told, ultrasound. But for an ultrasound to tell us PCOS, there should be more than 12 follicles with 10 to 10 millimeter. And follicles size should be to ovarian volume should be 10. So the 10 follicles, 10 millimeter ovarian volume. It can be in the one ovary or the both ovary. This is mainly for the adult. And as Sundara Meenakshi told, the needed investigation is TSH prolactin, 17-hydroxyprogesterone, 2 hours 75 gram OGTT, lipid profile. This free testosterone and androgen index is not needed. If at all needed, you can do. Otherwise, it is not compulsory. Ultrasonography only more than 8 years. These are all the desirable investigations. Serum androstenedione, serum DHEAS for any adrenal tumor, FSH, LH, if there is a menstrual irregularity, fasting insulin level, vitamin D3, free testosterone will come here, not here. So the ultrasonography, this is the desirable investigation. So you don't write all the investigations, only needed has to be done. And assess the quality of light and obstructive sleep apnea, as Radhika was telling, that has to be ruled out. And the body image issues, if they is obese means she will go for the psychological problem. Every day the adolescents, when they get up, first what thing they will do is they will see their structure and face in the mirror. So this is prevent the psychological effects. So now we will go with the management. Jyoti madam, do you want to tell up to this point anything?
No, ma'am, it's perfect.
Thank you. Then we will go with the, what is the main objectives of the treatment? Radhika?
Yes, ma'am. So main objective is treatment of the menstrual irregularity, and then the management of hirsutism and alopecia, and reducing the consequences of insulin resistance, long-term prevention of diabetes and hypertension and the metabolic syndrome, ma'am. So we have to mainly counsel her regarding the lifestyle, exercise, advise her to have good exercise, at least 15 minutes a day for 5 days a week, and also so that the pulse rate should be doubled, and then she should have a good diet, that is more of vegetables, less calories, and fruits. So we should advise her regarding the diet as well. And so these are the main things. And if they usually if they don't comply with this, we have to review them every 3 months and make sure the weight is reduced if they are obese, fall into the obese category. And if the weight is not coming down, and if they have a strong family history of diabetes, I usually add even metformin, ma'am. And it does regularize the cycles practically.
Okay, but it has no evidence, but it can be done.
Yes, ma'am.
So as she told Dr. Radhika, the lifestyle modification is the treatment for adolescent PCOS. The counseling, they should never skip the breakfast, because in the night, the insulin metabolism will be disturbed, and it is a cause for obesity. And reduce the carbohydrate to 40%, and 3 main meals, 3 snacks. Snacks being the salad, and 1,500 to 1,600 calories per day. You cannot tell the adolescents that don't take pav bhaji, pani puri, but you counsel them that you can be taken that at least monthly once, not frequently. So these are all the pictures you should have in your clinic. Rather than talking, if you put the pictures like this, they will be happy. These are all diet pulses, fruits, vegetable, greens, milk. They can be taken frequently. And these things can be avoided. That's all. But don't tell that don't take this. The whole family should support. Only the adolescent not taking this, but the mother is taking pav bhaji means it's not good. So the whole family should cooperate for the adolescent. And the exercises, as she was telling, 30 minutes per day, 150 minutes per week. So this will improve the reproductive future, menstrual irregularity, ovulation, and in future for the pregnancy also. So the daily exercise improves body's use of insulin and can relieve the symptoms of the PCOS. So if they are not able to do the exercises like walking, swimming, cycling, we can ask the simple exercises, getting off the bus and 2 stops earlier, and watching on the steps. And they should not take snacks when they see the TV. This is very, very important. And the sit-up exercises, skipping, this can also be done if the students, they are not able to go outside for a walking, swimming. Suppose they are doing the +2 and no time means, this simple exercise, sit-up is the best exercise I will advise. The gardening, home cleaning, simple exercises can be done. So this is the routine exercises and advise them not to take snacks when they watch the TV. Now we will go with this case. Suppose if the patient is having the menstrual irregularity, Dr. Sunanda, how are you going to proceed with the patient? Now the patient comes with history of amenorrhea, that is for 2 months. Then how are you going to proceed with these cases?
We can manage the patient with just progesterone, ma'am, like cyclical progesterone starting from day 5 to day 21 or 23. Or else we can give the patient just withdrawal breathing every cycle we can give for 5 days. Or else we can give luteal phase progesterones can be given for from day 15 to day 22 we can give them.
Yes, Nanda.
If the patient is having hirsutism, other features of clinical hyperandrogenism, then we can
That we
give
will come later. First, for the menstrual irregularity, you go with the progesterone as she was telling. It can be dydrogesterone 10 milligram, norepinephrine 5 milligram, medroxyprogesterone 5 to 10 milligram. So if the patient comes with history of amenorrhea, no other way with the progesterone, always rule out the pregnancy. That is one of the main investigations which we should not forget. Then you bring the withdrawal bleeding, and as she was telling, cyclical administration for 21 days from day 5 or during the luteal phase from 10 to 14 days. Suppose if the patient is having in between spotting only with the progesterone, then in that conditions you can go with the OC pills, that is low dose estrogen combined OC pills, which decreases the FSH and LH, reduces ovarian androgen production, increases SHBH and reduces the free circulating androgens increasing. So such that the SHSR, serum hormone binding globulin, will be increased. This is the way the OC pills is acting. Now, Dr. Saranya, if the same patient comes with the history of no menstrual irregularity, but with a face growth she is having and acne is present, pimple is present, how are you going to treat it? Dr. Saranya?
Ma'am, for facial hair, we can advise her on laser, like epilation therapies, laser, like it is affecting her day-to-day life. More hirsutism is present. We can go for mechanical methods, and she can, if she wants, she can go for depilation, like hair removal cream or shaving. It can be advised for her, ma'am.
So with that, after that, what will you do? The hair should, if you are removing the hair, then it should not continue the hair growth.
OCP,
No?
we can put her on OCPs, ma'am, with cyproterone acetate, which has a anti-androgen activity.
Yes, mainly the OC pills with the anti-androgen. That is the ciproterone acetate 10 milligram and 2 milligram ethylene estradiol. In this case, sometimes if they are obese, you can use the desogestrel, drospirenol, levonorgestrel group also can be used. So if there is a menstrual irregularity, go with the progesterone. If spotting is present, go with low dose estrogen combined OC pills. If androgenic features are present, go with the OC pills with anti-androgens. With all this treatment, the lifestyle modification is very, very important in all these cases. Jyoti madam, do you want to tell anything?
No, it's perfect, ma'am. You've concluded everything so well.
Yes. Now we are going with the insulin sensitizer. Now the patient is having the regular menstruation but obese. She is having that sometimes irregular menstruations, blackish colorations over the acanthosis, acrocordons, family history of diabetes is present. How are you going to treat Dr. Radhika?
Yes, ma'am. I usually, stress on the weight loss and exercise. But then if they have a strong family history, as you said, then we start them on metformin. And for at least 6 months to 1 year. And that is the main thing. And avoid carbohydrate, ma'am. And with COC pills, metformin actually gives good results. And it regularizes the periods, ma'am, most of them.
So if there is only the family history, you go with metformin. As Radhika was telling, for obesity also, metformin can be reduced. Some studies are there. If menstrual irregularity and acanthosis are present, means you go with the COCP, metformin, and the lifestyle modification. Always BMI should be maintained at 20 to 25. It should not be increased for more than 25. So this is the treatment, menstrual irregularity and with androgenic features and the insulin sensitizer is we are giving. So any one of you, do you want to proceed with the anti-obesity drug, Dr. Saranya or Sunanda?
We can give when the BMI is more than 30, ma'am, but initially we can, after while all the diet and exercise, everything fails,
Yes.
we can advise the patient, ma'am.
Do you prescribe this early start sibutramine?
Not for adolescents,
Physician.
ma'am. Mainly the patients trained for infertility or adult patients we give.
Yes, for the adolescent, always lifestyle modification for the obesity. So these drugs, if at all, as she was telling, for infertility, and in spite of everything, if she is not able to control means, then you can go with the metformin. And again, if it is not possible, you can go with the early start. Nowadays, people are using. Now another one product is launched by the MCure group of people. We don't know what will be the effect for this obesity. Then the metformin is generally not used for weight reduction, but though it is not producing hypoglycemia, but some cases it can be used. So what do you think about this laparoscopic surgery and bariatric surgery, Dr. Saranya?
Ma'am, in adolescents, like usually we don't advise, but with the morbidity, obese morbidity, only in cases with obese morbidity, we can go for bariatric surgeries.
Laparoscopic drilling?
Only if they are
Laparoscopic
trying to
drilling is,
conceive.
when we treat for infertility, like when she turns into
Yes.
adult.
So laparoscopic drilling is not a separate procedure. If at all goes for the infertility. So now the girl is so obese, she want to get married, but she is not able to become thin means in that cases, final stage, we are advising the bariatric surgery, but not earlier. So as far as adolescent is concerned, only the lifestyle modification is the treatment. Diet. That's all. Then if at all needed, early start can be given. This laparoscopic drilling and bariatric surgery, we don't advise for adolescents. So myo-inositol, any one of you can take up this question. What do you see your preference with myo-inositol? Inositol group.
Myo-inositol generally acts like metformin in regulating the insulin resistance, ma'am. But many studies have role, but it is not recommended according to the evidence, but it has role in reducing the metabolic disorders as with metformin.
So now there are little studies are there. Rather than going for the hormone therapy, myo-inositol and dithyroninositol 40:1, that is secreted from the ovary only. That can be given as a sachet from 2 to 4 grams, morning one and evening one, and which proves that it reduces the hirsutism and menstrual irregularity is corrected, and acanthosis nigricans, obesity is also getting reduced. But I am using this myo-inositol and dithyroninositol because there is no side effect. But some people, they don't prefer for the adolescents. So this is this.
Actually, they tell this myo-inositol is just a protein molecule. It doesn't do anything, but it modulates the testosterone hormone level. So it can be used for adolescent girls with acne. But I'm not using, ma'am. But studies, it tells like that. I am not using it, ma'am.
Ma'am, myo-inositol even I am not using, and this alone has not given good results. Initially, I did try, and it becomes very expensive for the patient. Many times we don't get very well off patients, so we try to avoid things like this.
Yes, if they are affordable rather than hormones, it can be used, but it is your wish. It is, as all of you are telling, there is no evidence, but it can be tried as a placebo and with exercises. So this is the myo-inositol group. Now we come with the case. 15-year-old girl had a board exam and came to OP with complaints of excessive hair loss, amenorrhea since 4 months, acne over the shoulder area, history of similar episode last year. BMI is 22. So how are you going to manage, Dr. Radhika? Sundara Meenakshi is there. Dr. Sundara Meenakshi, how are you going to manage this case?
Yeah.
Ma'am, she is a 15-year-old ma'am, but her BMI is only 22. So she is not obese PCO, overweight PCO illa ma'am. But she is definitely a case of PCO because she is having 2 criteria. One is androgenic features and number 2 is amenorrhea. So she comes under PCOS. So this person, still I would ask her to go for lifestyle modification, walking, exercise. Still her BMI is only 22. Another thing, I will go for OCs, ma'am. OCPs to regularize a cycle, withdrawal bleeding, and then OCs.
So the lifestyle modification is very, very important. If at all not possible, as she told, you can go with the OC pills and regular follow. Yes,
Ma'am, shall I add a point, ma'am?
yes, Chitra.
She has completed her board exams. Her stress level would have also been increased, ma'am. So you have to note that also.
Yes, always +2 exam, better not to treat.
Yes.
Once the exam's result has come, we can start treating. That is the stress level. Yes, that is also has to be noted. So always follow up the patient. This can be continued maximum of 1 year, and then follow up the patient, and the lifestyle changes has to be continued throughout. That is very, very important. Yes, Chitra, you take up this question. Girl, 17-year girl with recently joined college. She is in hostel life, fond of fast foods, always burger and cola, and came to OP with irregular cycles and no history of anti-androgenic features. And from the Google, she came to know if there is a PCOS, means she can develop cancer in future. What will you do with this patient, Chitra?
Does she have any menstrual irregularities, ma'am?
No, nothing. Yes, yes, irregular cycles is present. No androgenic features.
Yes, ma'am. Ma'am, we can definitely she need to be advised about her diet, ma'am. She has to change her diet. Not for now. She may be end with the weight gain. So we have to reassure her, advise her with diet and exercise, ma'am. That's enough, I think so.
Yes, lifestyle is very, very important. That as I told earlier, the diet and exercises. Suppose if the irregularity cycle is
We
not
can give
controlled,
OC pills, ma'am.
if needed. Otherwise,
Yes,
lifestyle is the treatment for many of the adolescent girls.
And one more point in this case.
Yes,
since
Dr.
you
Jyoti.
mentioned very anxious. So she should go in for meditation or yoga, something like that, so as to cool her nerves.
Yes, you can tell, but do you think this adolescent will go for meditation?
Madam, these days there is a trend that they go for yoga and
Yes.
Pilates.
Yes, if they are willing, they can go. Main thing is that anxious should be controlled. So many of the time they will show the anger only to the mother, not to the friends. So the only thing the mother should avoid her. If the girl is getting angry with the mother, means there is some problem. That itself is an indication. Okay, so anxious, as Madam was telling, you can advise her the meditation also. So this is our final case. 17-year-old girl with gynecopedy, complaints of excess facial growth, and the growth has increased even after the cosmetic therapy. She is not able to walk confidently, and the score is around 10. Her father is also diabetic. So, Dr. Sundara Meenakshi, what is the treatment you want to give for this patient, for this girl?
Ma'am, her cycles are regular. She's only hyperandrogenic alone. Her cycles are regular cycles. This patient, I would definitely go ahead and investigate for a serum hormone testosterone levels, ma'am, because her hirsutism is recurring even after cosmetic therapy. First, I would keep myself safe by investigating hormone testosterone levels, rule out any other pathology that I am missing for this patient. Otherwise, this patient, I will advise her OCs, especially with cyproterone acetate combination, ma'am.
Yes, that is the treatment. So that adrenal secreting tumors has to be ruled out, as she was telling, adrenal hyperplasia, and OC pills with anti-androgen. And since her father is also diabetic, you can also add metformin if you want. Otherwise, if you don't want, you can avoid that. Jyoti madam, do you want to tell anything for all
We
three
usually
cases?
add metformin because it is known to be a immunomodulator also. So it gives better results if you add metformin.
So finally, if the adolescent comes with the PCOS, means first elicit the history. Lifestyle is the treatment. If the irregular cycles, go with the progesterone and OC pills. And if androgenic features are present, OC pills with anti-androgen, insulin resistant features and family history present, you add metformin. Whatever may be the treatment, lifestyle is the change of the patient. So in these cases, I would like to consider myoinositol also, because I am fond of myoinositol. If needed, I will consider this rather than going with the hormones. So this you can counsel the patient. These are all natural hypoinsulinemic agents. That is soybean, neem, amla, onion, garlic, turmeric, fenugreek, jamun. They can be taken. There is no harm in this. So the take-home message is lifestyle modification is the first line of management for the adolescents, and individual PCOS manifestation. That can be whether it is a menstrual irregularity, whether it is a androgenism, and whether it is an insulin resistance. And depending on that, the treatment should be CO progesterone, CO OCP with anti-androgen or without anti-androgen. And the metformin is recommended in the insulin resistance cases and with the to avoid the metabolic features. And the response always assessed after 6 months to 1 year. Some patients, they may take even for the 2 years. So always the adolescent PCOS, identify it earlier and counseling, give her the counseling. So this is the, I always do with the patient counseling. We will go with one point. Dr. Radhika, what will you tell for the adolescents? Radhika is not. Sundara Meenakshi, 1 point for adolescent PCOS.
Ma'am, one question to you, ma'am. Ma'am, if the patient is on OCs, you will give for how many months, ma'am? Years
6 months.
together or months, ma'am?
6
Because she's
months
only
to 1 year.
15. 1 year. Then we will stop and see whether she automatically responds to her natural cycle. Again, these people come only with irregular cycles.
No,
in
that time
2
you
months they
have
tell
to,
the cycles are regular, and after that they come with the missed periods and irregular cycles, same that acne and all those
the
things. ma'am.
lifestyle.
Again, we will continue for
No,
1
no,
year
no,
or
no, no.
how?
No, first you can continue for 1 year and the lifestyle has to be followed throughout their life. That is the lifestyle. So if you are going to give the OC pills and she is going to take burger and she is not going to walk, then there is no point in giving OC
No
pills.
point.
Some girls, they are continuously fond of tablet. In that cases, you go only with the progesterone from the for 10 days and you can continue, not the estrogen at all time. Some patients are taking even for 5 years. So
Yes,
counseling is very, very important. Radhika, 1 line.
Yes, ma'am. Yes, ma'am. Lifestyle modification, ma'am.
Yes, lifestyle is the treatment. Saranya?
Treatment. Zumba.
Yes, Zumba, whatever is possible. Sunanta?
Yes, ma'am.
Primarily lifestyle, ma'am.
Lifestyle. So lifestyle, you have to tell what is life, what is style. Then only they will understand. Dr.
Diet
Chitra?
counseling has to be given.
Yes.
Please,
Yes.
30 minutes of exercise.
Dr.
every
Chitra?
day.
Ma'am, first thing I would like to give advice is diet, ma'am. Diet, then exercise and stress-free life.
Yes, stress-free life, as she was telling Zumba and everything. Saranya has told Zumba, I think. Dr. Jyoti, even
Strong,
one word
stay
reply.
fit.
Yeah, in my opinion, the mainstay would be the diet, a proper diet chart to be followed always. And the second would be the exercise. The muscle strengthening exercises would be good for them. Or simple
Yes.
walking for maybe half an hour, 5 days a week.
So for adolescent, lifestyle is very, very important. I thank all the panelists and our expert. And I request all of you to support me. I am contesting for the Foxy President. Election year is 2026. Please spread the message to your members and support me. We can talk from adolescent to menopause. Harpada Parswa. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you,
Thank
ma'am.
you,
And
ma'am.
Wish
we
you all the best.
definitely
Wish you all
support you.
success.
Thank you, Dr. Jyoti and all.
Thank you,
Ma'am, we would not get a president like you who is so down to earth and it's having all the knowledge in the world and so simple also. So we'll
Thank you.
definitely support you, ma'am.
Thank you.
And ask our
Thank
members
you.
to
Sure,
do
we'll support you, ma'am.
Yeah, thank
Thank
you.
you,
Thank you, Dr. Padmini. I think.
All the best to you, madam. And
Thank
then
you, Dr.
you have
Padmini.
selected 2 topics which are perennial. They come to us repeatedly, both adolescent PCOS and endometriosis. And there is a dilemma in the treatment. And then you have selected a very good topic and you have shown so much of insight into that. And we wish you a success,
Thank
madam.
you. Thank you. Dr. Srilata has joined. A few words,
Yeah,
Dr.
madam.
Srilata.
Yeah, madam. Yeah, madam. I just joined last 15-20 minutes. I really missed the topic, but all the best, madam. Will definitely support you. And really, these are very, at least the lifestyle one, the last message I received it, it's really wonderful. I think I catch it at the right time, I think, ma'am. All the best to you, ma'am. Yeah.
Thank you, Dr. Srilata. The link I will put in the group. You can go through that link also.
Oh, yes, ma'am.
So
Yes,
the
ma'am.
Dr. Madhumita,
Thank you.
formal vote
Yes,
of
ma'am.
thanks.
Yes, ma'am. So coming to the end of this wonderful webinar, I would first and foremost, I would like to thank Dr. Sampath Kumari ma'am for bringing us this wonderful webinar series. The President and Secretaries of Jagatyal Society, Dr. Padmini and Dr. Srilata, Korutla Matpalli Society, Dr. Sweeti and Dr. Hepsiba, Hapur Society, Dr. Anjana and Dr. Renu, Sagar Society, Dr. Jyoti and Dr. Nidhi. And I would like to extend my heartfelt gratitude to Dr. Ramani Devi for her wonderful talk and our esteemed panelists, Dr. Sarnya Devi, Dr. Sunanda, Dr. Chitra, Dr. Sundara Meenakshi, Dr. Nidhi Jain, and Dr. Radhika Gauri for the wonderful and insightful panel. And I would like to thank our expert, Dr. Jyoti Chauhan ma'am, who has been with us throughout the session, and also Dr. Padmini Kumar ma'am. Thank you, dear delegates, for your for joining with us today. And I would like to thank Priya and Sahiti for the technical support. Thank you very much,
Dr.
everyone.
Madhumita, for her sweet moderation.
Thank you,
Thank
ma'am.
you, all of you.
Thank you, ma'am.
Thank you.
Thank
Good
you so
night.
much.
Good night.
Good night, ma'am. Bye, ma'am. Bye, ma'am.